Good afternoon to all. This is Dr. Rahul Lakshminarayanan from Hyderabad. I'm here today to talk about off-label use of iliac limb in the abdominal aortic aneurysms in an Indian population with small aortas. Um, it's an off-label limb, so we have to look as to whether it's a necessary risk we're taking or whether it's an evolving indication which we should look at along with the other companies and the other healthcare providers with us. Can I go to the next slide? It's a dream. Right. So I have no disclosures. So EVAR is obviously an important part of every vascular surgeon's skill set. And there have been multiple studies showing that the aortic diameters in the Asian and South Asian populations are generally reduced compared to similarly matched populations in the Western populations. The issues which may happen in such patients with smaller aortas are often with graft introduction as well as post-deployment, the kind of issues you may encounter. If you're putting larger grafts in smaller aortas, you may have guttering, endoleak, and multiple repetitive interventions. So this is one such study which was published in 2011, which showed that there were, apart from the well-established changes, increased aortic diameters with age, sex, and body surface area, there was also a significant reduction in the aortic diameter in Chinese Americans, African Americans, and Hispanic populations in America in comparison to Caucasian populations. Another study which looked at changing trends in aortic sizes worldwide showed that in the Asian as well as the South Asian populations, the aortic diameters were relatively less compared to the European, North and South American, and there was a significantly increased size in the aortic size in the Oceanic or Australasian populations. So with that background, we just wanted to talk about two cases we had recently treated. So one was a 26-year-old female with sudden onset worsening abdominal pain over 1 week, and her body surface area was 1.19 meters square, which is relatively quite low. She's a thin-built girl who had come with complaints of sudden onset abdominal pain for 1 week. As the CT angio shows, there was a suprarenal, just above the SMA, there was a saccular aneurysm with contained rupture. And this is the CT angio of the patient. So it did show a contained rupture with a lining thrombus with the compression of the SMA just under that. The celiac artery was occluded for the patient. So we balanced all pros and cons of open surgery versus totally endovascular, and we decided to go ahead with a hybrid option for the patient. So we planned our graft such that we would be deploying it in the suprarenal segment and sparing the renal arteries. And we did a bypass to the plan for a bypass with a prosthetic graft from the iliac to the SMA. So this was the laparotomy and the intraoperative findings. The initial angiogram post bypass, which showed the Persson opacification of the aneurysm, and the deployment of the sac. So on the right, you can see the completed picture where the sac is not opacified and there's good perfusion of the renals, and the SMA is well perfused through our bypass graft. This patient also did on table have an occlusion of the bypass graft, which required an embolectomy on table. But following that, the final picture shows a persistent flow through the bypass graft. And this is the post-operative picture 3 months later, which showed good stent opacification, non-opacification of the sac, and patent bypass graft. Another patient, a 16-year-old female who had likely vasculitic issues, history of primary APLA, IVC thrombus, and a CSVT. The patient had been treated with anticoagulation, and subsequently, about 6 months later, had come with abdominal pain. And evaluation with the non-invasive imaging had shown a saccular aneurysm. So for her also, she had a reduced BMI and a body surface area. So with this patient, she had an aneurysm in the posterior aspect of the infrarenal aorta with a posterior sac. So as you can see from this patient, from the CT angio, it shows the aneurysm limited to the infrarenal aorta alone. Again, because we had a good assumption, we clinically assumed that the patient would have vasculitic issues with IVC thrombus, significant collateralization, and with her body habitus, we didn't want to risk her for an open surgery and the possible blood loss and other issues. So we decided to go ahead with a endovascular stent deployment. So for this patient, we went for a 13-13-82 graft along with our Medtronic healthcare providers. So this showed the sac opacification preoperatively, and this is the stent graft deployment. We made sure that we stayed above the aortic bifurcation to avoid caging either of the iliacs. And the left is the still image of the sac opacific, and the right shows the completion picture. And this is the completed. This is about 3 months later. We repeat CT angio showed non-visualization of the sac at all. So all studies looking at aortic sizes, there is significant heterogeneity. Many studies look at ultrasound, many studies look at CT. There is outer diameter versus inner diameter. And suppose you're looking at aortic diameters, where do you look at aortic diameters for comparison? You can, many papers will be talking about a thoracic aortic level. Some will look at bifurcation, some will look at a suprarenal level, some at the bifurcation, aortic bifurcation. But there is no uniformity in, if you look at all the studies, as to where exactly they're measuring. And therefore, the results, of course, can vary, because at every level of the aorta, it does vary for that reason. So despite that, there is significant agreement among all studies that there is progressive increase in size with age, sex, weight, height, body mass index, and body surface area. So looking at multiple studies, we focused on data specific to infrarenal abdominal aortas, and looked at geographical differences. So looking at geographical distances, we did find that there was a significant reduction in the Asian aortic diameters, especially if there were 3 studies we've looked at from India as well, which showed a significantly reduced aortic diameters. This was one of the studies which has been carried out by one of our colleagues, Dr. Ajay Savlana from PGI from Chandigarh. He's found the same thing with a significant variation in the Indian as well as the Western population. Another study published about 8 years back from CMC Vellore has showed a significant variation. So, along with age, sex, and other issues, there is a significant aortic diameter which is roughly keeping the aortic diameters in the range of 13 for males and around 12 for females, which is quite different from what the general worldwide population studies show. At our own institution also, our data show the same kind of changes. With age and sex, there is a progressive increase in the size, and there is a significant difference between males and females as well. So in conclusion, there are challenges to treating patients with small aortas. You'll need to use smaller stent grafts, and although the IFUs don't cover the use of iliac limbs in these kind of patients, it's something which may have to be looked into in modifying the IFUs as well. And of course, the associated safety analysis, which will have to be carried out for the same. Right. Thank you.